there is a huge need for more and better therapies for patients that have had a complete resection but are at risk for recurrence. We have a huge amount of activity in doing clinical trials, both in the neoadjuvant and adjuvant setting, but in 2018, that is future data and future opportunity, but not necessarily available today outside of a clinical trial. So I think the important thing in 2018 in the adjuvant setting is to make sure that every patient that can receive chemotherapy receives it, and the standard of care for adjuvant therapy for lung cancers is a cisplatin-based regimen. The second thing is for patients that could have benefit from radiation, and those are cases with evidence of mediastinal lymphadenopathy at the time of surgery, that those patients be considered for radiation, and that we should take the therapies we have today and take them forward. I think there's an extraordinary amount of evidence available that adding in a TKI for EGFR mutant lung adenocarcinomas that are completely resected makes that an alternative that I think can be considered for individual patients. I try to consider it in every patient that has an EGFR mutation, and I urge you to think about its value for your individual patients. But again, that's something that there is not wide consensus. Out of 10 oncologists, I'm probably the only one that would recommend that routinely. But I ask you to think about it for the right patient.